The final slide in way of overview of the course is just some of the challenges that we'll be facing over the semester. One is related to this format. It's still new to us, new to many of you, and we ask your patience that with this kind of experiment along the way, I think it has a lot of virtues. It'll allow us to make better use of the time we have together, and I'm really looking forward to it. I'm excited about it, and I hope that you'll be patient with us again and feel free to give us constructive feedback along the way. We're also still dealing, as I mentioned before, with a social determinants of health curriculum in evolution, unfortunately, still the case. And that, again, continues to have ripple effects. So I'm also likely to be making a few adjustments in content over the course of the semester after I get a better sense of how much you've retained, those of you in the core, since that time a year ago. And also kind of related to that, always is the challenge of disparate student backgrounds, prior experience with the material, backgrounds ranging from biology to critical social theory and everything in between. And now many of you will also have been in the core and many of you won't. And so I've highlighted and will continue to highlight material where you can skip over it, glance over it, just go through it briefly if you had it in the core, or pull up your readings and refresh yourself, go over those notes you took meticulously during the core on a few of the readings that will be repeated here. Or if it's totally new to you, then you'll have an opportunity to get exposed to that material for the first time. Another challenge that's an ongoing one is to move beyond a very Euro and US centric focus of the literature, and this stems from the fact of historically much of the sort of pioneering work in this field and most advanced work methodologically is in these regions, but particularly with our global students involved, we're really going to seek to go beyond that even more than in the past. We'll also be really looking for your input of examples of studies taking place where you're working, where you've worked in the past, to really animate and give more illustrations of the content that we're covering here. And again, even though this is in many ways a survey course with some depth, we're still at a loss and not totally achieving the kind of comprehensiveness we might want to have, but we'll hopefully be able to use supplementary sources along the way as resources that won't be mandatory components of the course, but opportunities for people who are interested to go further than what we're able to do. Very simple, obvious rules of engagement. Your attendance is mandatory. If you can't make it, we need to be informed in advance of that fact and why. Your participation in class and for the online students on the discussion boards is going to be central, really kind of critical part of the class for it to work. And again, but there are many ways that you can achieve that participation. Deadlines are hard and fast, fixed, extensions available only in a really emergency situation with advance as much as possible, permission, and general kind of accountability. Again, that has a lot to do with communication, communicating about needed absences or extensions and so forth, and accountability therefore to each other, that if you're not going to be there, we should all kind of be aware of that and giving us notice and etc. So you have a general sense of everybody's here and participating. And during those sessions, both online and in class, we want to exhibit respect for each other's opinions, divergent points of view, background, familiarity with the material, etc. Some of this material, as you know, can be sensitive for people, touch on people differently in their personal lives or the lives of their families and communities, and we really want to exhibit the highest level of respect for that diversity. And academic integrity goes without saying. If you haven't read the handbook, do so. If you have any questions about what's okay and what's not, don't get yourself into a bad situation. Ask for help or reach out if you're in trouble early on. Don't wait until it's too late. I'll pause here, let you stop the video, and John and Carolyn can answer any questions you have about the requirements and the way the course will work that I've touched on so far. Okay, briefly wanting to move on to today's topic, really defining what social epi is and related constructs, talking about it within the wider discipline of epi, and then just really briefly touching on some of the key antecedents to the modern self-described discipline of social epidemiology. Definitions: the branch of epidemiology that studies the social distribution and social determinants of health. A little bit more elaborated by Krieger. It's distinguished by its insistence on explicitly investigating social determinants of population distributions of health, disease, and well-being, rather than treating such determinants as mere background to biomedical phenomena. And this gets to the point of social epidemiology as really pushing to the forefront the social conditions in which people live as things of empirical interest and importance to public health, rather than the things that we sort of try to get out of the way so that we can understand more proximate determinants of health outcomes. A few other key definitions here and concepts. This is shown on in the Canvas page. Social determinants of health is a broader concept referring to features of and pathways by which a range of societal conditions affect health and that can be altered potentially by action. And there's a distinction here between disparity and difference. The disparity corresponds more to the notion of social inequalities in health. Health disparities within and between countries that are judged to be unfair, unjust, avoidable, and unnecessary, and that systematically burden populations rendered vulnerable by underlying social conditions and political and economic legal institutions. So here the emphasis is on things that are unfair, that reflect an unequal starting point in life, and that can be modifiable by human intervention or are the product of human action or inaction. And health inequalities, in contrast to social inequalities, can be interpreted, and often is, to refer to any difference between groups, social groups, and not specifically to unjust disparities. So that's just sort of to cover some of the terminology that we'll come across and to recognize the ways in which they are interchangeable and, importantly, are not. So what are some of the questions that animate social epidemiology? Why is the life expectancy of Black men in Harlem lower than that of men in Bangladesh? Why is the health of the better off in the U.S. worse than the health of the less well off in the U.K.? Is the health of poor places bad simply because poor people live there? Why are there social disparities in health above a level of absolute resource deprivation? And why do gaps in health between the rich and the poor get worse over time? And despite overall population health improvements, is poverty bad for health? If poverty is bad for health, why does physical population health improve during periods of macroeconomic downturn? Two questions I want to flag just to put them out there. I'm not going to really answer these to your satisfaction perhaps, but I want to embrace these questions and encourage you to wrestle with them and bring them to our discussions. I want to flag them now as things that we can come back to. What is social epidemiology good for? Don't we already know that things like poverty, racism, etc. are bad and should be changed? And how practical is it to intervene so far upstream? And is it the business of public health to try to influence non-public health policies? I'm not even at this point going to give you my take on these questions, my answers. I'd like to hear what you have to say and again collectively kind of wrestle with them over the semester. Some of the historical trends in really crude macro terms that help us anchor what the current modern era of social epidemiology is coming out of, I'll just here refer to basically two in really crude terms. One is an earlier infectious disease focus of epidemiology, where the approach was quite elaborate in terms of attempted theories of miasma, contagion, germ. These were very elaborated theories about what are the mechanisms by which illness arises across populations. But the tools to really understand those processes were incredibly weak. And so the ability to test those theories accordingly was also very weak. And then when we move into a chronic disease era of epidemiology, what we see is with the emergence of better tools, it's kind of related or not, the abandonment of theory. Here we get into risk factor epidemiology, or what's been referred to more disparagingly as black box epidemiology, where we have the machinery, the computing machinery literally, to test the associations between a bunch of things. And we throw everything into the mix and see what pops out as statistically significant, and then look for that as the answers that guide our understanding of the risk factors that give rise to disease and premature mortality. This modern epidemiology then is focused on chronic diseases, very individual level understandings of determinants of disease, focusing on these multiple risk factors, or what's often referred to as this web of causation, where there's like a non-hierarchical relationship between these determinants. They're sort of all equally or differentially implicated in a particular health outcome, but not in a kind of hierarchical way. Lacking in theory and characterized in its totality very much in terms of biomedical individualism. And McMichael is one of the many early critics of this modern epidemiology and its focus on individual versus population risk factors and patterns, very proximate determinants of disease versus distal, very focused on a sort of static, in the moment, causal identification versus something appreciating determinants varying over the life course, and as such is then kind of anchored very much in the past or the present, as opposed to being future oriented. And I won't elaborate on this because this is one of your readings, but it's worth focusing on this for a moment just because it points to what was sort of the reigning era of epidemiology from which social epidemiology emerged. The responses among social epidemiologists were a few, among others, to point to the relevance of context and ideology in the production of science. These are social, political, and economic factors that influence the social production of science. The importance of making theory and assumptions underlying causal ideas and models explicit. If they're explicit, they can be challenged and tested. And challenging, importantly, implicit normative attitudes regarding individualistic lifestyles and personal responsibility, highlighting instead the role of social context. A lot of that normative, bad behavior, victim-blaming kind of mentality of the 1980s, for example, was really permeating epidemiology. A lot of that really came to the forefront around the AIDS epidemic and its emergence at the time. And pointing to, well, people behaving badly is why they have poor health, which really negated the role of social context in influencing individual behaviors, but also influencing health, vulnerability, susceptibility, and general well-being independent of any individual's own health behaviors. Some important antecedents. Emil Durkheim is considered in many ways a grandfather of social epidemiology, certainly a reigning figure in sociology. And his work looking at suicide was a really important study which contextualized a very individualized health outcome, which is suicide. So what his work did was really recognize the extent to which individual agents are operating under the influence of their social context. Specifically, he was studying the rates of suicide among Protestant communities compared to Catholic communities. And rather than focusing on anything about religiosity or the particular practices of those groups, he identified that the relative degree of social integration characterized by those different communities was one factor that could importantly explain the fact that the rates of suicide in these two types of communities were different, but yet consistent over time, consistently different from each other over time. And the McEwen thesis is one, again, that's highlighted in your readings. This is a critique of the medical establishment and its sort of primacy in a particular time in the 19th century and earlier. And McEwen's thesis was basically that what we enjoy is 2 centuries of health improvements and population growth is attributable more to social and economic progress than medical or public health interventions. And this has been a controversial thesis over time. Some of its tenets and the evidence upon which it's based have been questioned. But the central idea has pretty much had long staying power, which is that we owe this progress in health more to public health types of interventions and even social welfare interventions, as opposed to medical clinical interventions. And of course, Jeffrey Rose is an important antecedent. Those of you in the core, have encountered his population perspective already. We are going to revisit it in this module and also some commentaries on his influential piece on sick populations, because this is really an important anchoring of ideas and evidence and ways of thinking about population health that reflect a lot and speak to a lot of social epidemiology approaches. And today what we have is sort of this mishmash of concepts and a lot of overlap in the terminology and the approaches to understanding health outcomes that are probably really semantic differences in many ways. You can split hairs about the differences between these terms, but the broad concept of understanding health at population level and really focusing on the upstream factors, the social context, the features of the social environment and social conditions that are differentially patterned are what we are going to be focusing on as the important drivers, the most important drivers of the distribution of health across populations in society. I will leave this here, and I allow you to now go on and introduce each other to each other, and then also to view the documentary segment. And I really look forward to meeting you in a week. Thank you again, and again, sorry I can't be here.